Excited to have you with us tonight. We have an exciting program for you celebrating Mental Health Awareness Month. May is Mental Health Awareness Month, and so here at the People Concerned, we've been having several opportunities to share the work that we're doing here at the agency. So I'm very excited tonight to be joined by several of my colleagues who are on the front lines in this really important work, and you're going to hear a lot more about that in just a minute. We do have two parts of our program tonight. So the first part, if you have questions, there'll be about 20 minutes of the presentation and about 10 minutes for Q&A at the end. If you would put your questions, please, in the Q&A function. That's at the bottom of your screen. There's a button there, and you can just type the questions in there, and we will give them to the presenters, and they will do their best to answer as many of them as possible. The second part of the program is a trauma-informed care workshop. We will not have time for questions directly to the panelists, to the presenters, but we are happy to aggregate all the questions. You can put those in the chat function, and at our post-event wrap-up, we will answer all of those questions in writing. So just a quick housekeeping reminder. If you would please make sure that you stay on mute. We have many participants on the call this evening, and so we want to make sure that we're not distracting with background noise from the presentation for any of our presenters or panelists. So please make sure that you stay on mute. Again, a reminder for the first part, please put your questions in the Q&A. For the second part, questions in the chat. And with that, it is my pleasure to introduce my colleagues, two of my colleagues, Naomi Levy, who is our clinical director in the mental health department, and Lauren Gonzalez, who is the director of our full service partnership program, and they're going to be leading a conversation on our mental health programs. So welcome, Naomi and Lauren, and take it away.
Thank you, John.
Thanks, John. Well, good evening, everyone. Thanks so much for joining. As John mentioned, I'm Naomi Levy, and I am the clinical director here at the People Concerned. Laura and I will be collaborating together to talk a little bit about services that we offer here in the mental health department at the People Concerned. So to get started, just to kind of give an overall perspective of the kind of work that we do and how we formulate our approach, we have program participants who are supported through an integrated, client-centered, wraparound type service. And so we really pride ourselves on taking a multidisciplinary approach, meaning that our clients are wrapped around with folks who have various expertise, whether that be clinical services, medical, outreach and engagement, crisis management, psychiatric services. We also provide case management, which essentially provides linkage and referral. Individual and group counseling services. And recently, we've actually expanded those services to include couples, family, and child counseling services to ensure that we are addressing the individual holistically as well as their support system. We also provide substance use support as well here at the agency. And all of those services that we provide, whether it is, regardless of the program, is really rooted in some various commitments to trauma-informed care. That is a model that essentially addresses individuals' trauma histories from a perspective of safety and collaboration, strengths-based and choice, which you guys will be learning a great deal about a little bit later today. Harm reduction, which is a public health model. I'll be talking a little bit more at the end of the presentation in regards to reducing harms associated with any type of risky behavior. The housing first model, which essentially is rooted in the belief that all individuals deserve a home. It is a right and not a privilege to be housed. And so we do not set up barriers or hurdles to folks moving into housing, but that is always the #1 priority. And we don't ask people to do certain things prior to moving into housing. And lastly is diversity, equity, and inclusion. And so we are always looking at these particular aspects, ensuring that we are both diversifying our workforce force, ensuring that we are taking these particular pieces and making sure that we are addressing individuals dependent on their individual identities.
Okay, so good evening, everyone. I'm Lauren Gonzalez. I am the director of the Full Service Partnership Program, and I'll go over a little bit about what that program is and the services that we provide. I'm going to go over the programs in our mental health department and break it down in terms of the services and the people that we serve in these programs. So first, we have our Wellness Center. This is located in the Skid Row community in downtown Los Angeles, and the services provided there are mental health services, counseling, psychiatric medication, case management, life skills, and support groups. Due to the pandemic, we had to kind of scale back our in-person support groups, but we do have some groups that we do over Zoom. Again, we do serve the Skid Row community, and it's located in downtown. The team there is made up of 10 clinicians, so that's master level therapists who are providing those clinical services to our clients. In addition to that, we have case managers. And in general, what our case managers do is they provide resources, referrals, and linkages to help clients meet our goals. And the very core of that is the housing first model that we follow. And the director of that program is Jennifer Garcia, and the medical director of our agency is Dr. Sarah Hune, who's based out of the Wellness Center. Next up, we have our field-based mental health program, and this program is actually located in the West Side. We have services both in downtown and West Los Angeles. This program is made up of four case managers and 6 clinicians, and those services are scattered throughout our interim housing program. We really want to operate in a way where there's no wrong door for entry. We have outreach teams outreaching folks in the field to connect them into services. We have access centers and interim housing, and so we want to make sure that we're removing barriers as much as possible to get clients the care and services that they need, because as we know, it takes a village to serve our folks. The locations out of the field-based mental health team is out of our interim housing programs in Cloverfield, Turning Point, San Michelle, and then the West Side Access Center. And those services include the field-based mental health services. So services are operated out of the shelters and access center, but also we do also physically meet our clients where they're at. Again, we want to remove as much barriers as possible. We know with transportation and just mental health and medical concerns, it's not always feasible for our folks to go to an office or building to meet with their providers. And so we really emphasize low barriers as possible and them going out to the field to meet our clients where they're at. So in addition to that, they also provide counseling services, case management, psychiatric medications. We have psychiatrists on staff for that program and housing retention. We always emphasize that it takes a lot to house someone, but also it takes a lot to keep very vulnerable people housed. And we want to make sure that people are being successful in the housing that they're moving into. And Erin Hill is the director of that program. Next, we have our West Side Outreach. It's very exciting, have expanded our West Side Outreach programs. They are broken down into a few different teams, one of those being C3 Santa Monica, and then the HMS team, which stands for Homeless Multidisciplinary Street Team. And also too, we now have a West LA outreach team made up of 2 outreach case managers. And we also have a outreach team that does outreach primarily focused on Malibu and Pacific Palisades. So they have a very nice view when they get to work out during the day and outreach to folks in the very gorgeous beachfront areas there. And overseeing those programs are Zachary Coyle, and we really emphasize collaborating and coordinating internally. We work with our outreach teams. They are the ones outreaching folks and providing street medicine, psychiatric services, crisis management, case management, and making sure that we're operating from a multidisciplinary model, because we want to, again, provide those wraparound services for our folks. And we work really strongly collaboratively with the outreach programs, both with our interim housing and our field-based mental health services. There's constant daily interaction to make sure that we're providing, the highest quality care of services to our clients. And at the core of that is strong collaboration of services. Zachary Coyle oversees all the outreach programs in the West Side. Okay. So this next program, this is the program that I oversee. This is the Homeless Full Service Partnership Program. This is considered the highest level of care of outpatient services. So we work with people who meet criteria for severe and persistent mental illness. They typically also come with a long history of chronic homelessness, chronic medical health conditions. And so that's why our team is equipped with not just clinicians, but also case managers. We have psychiatrists on staff, which is really exciting because our psychiatrists go out to the field. Our psychiatrists are hiking through certain encampments sometimes to make sure that their clients are getting their meds. And we also have street medicine. We partner with Venice Family Clinic, both for our full service partnership program, as well as our street outreach teams. And we cover the downtown metro LA, so central LA area. And we also cover the Santa Monica West Side area. And in total, we have 13 clinicians and 11 case managers. All our services are field-based. We want to remove as much barriers as possible. And so we operate from the relentless engagement model of really meeting our clients where they're at and ensuring that they're getting the services that they need. And we prioritize housing first model at the core of that. This next program is our housed full service partnership. So the difference is that once we get our folks into permanent supportive housing and they've adjusted to the initial move-in and getting their needs met, both with all their essential home furnishings and making sure that they have all the providers they're connected with, we will, on our end, transfer them over to the housed team. And this is a program that's specifically dedicated of clinicians who work with folks who are in permanent supportive housing. Because as we know, just because someone gets housed, they even need more support as if they were prior to them getting housed. So this has also contributed to, housing retention and success. We want to make sure that our clients are continuing to get the medical and mental health services needed for their care and just to be successful long-term in housing. And our housed full service partnership team of clinicians are located at project-based sites, both within our agency and outside of our agency, as well as scattered sites. So folks with vouchers living in various apartment units throughout the county. And Sonia Estrelon is the director of the program. And we just also want to share some exciting outcomes and successes that we've had thus far. Our fiscal year starts July 1 of 2020. And so since July of 2020, our programs have housed 215 participants. Our Westside outreach programs have outreached and engaged more than 1,000 people experiencing homelessness, our unhoused neighbors. 225 program participants have access services in the Downtown Wellness Center. The full service partnership programs have provided intensive outpatient services to 255 program participants. House Full Service Partnership has provided more than 198 clients with services in permanent supportive housing. And field-based mental health has served 93 program participants out of our own agencies, interim housing services and access centers, so Turning Point, San Michelle, and Cloverfield. And here's just a general overview of our interim housing. Recently, we were able to integrate both our interim housing and mental health programs into one department, which we're really excited about, and just really strengthening the continued collaboration between our mental health programs and our interim housing sites. We often find that a lot of the most vulnerable people that we encounter are not connected to any services, but are in some of our shelters. So we really want to remove barriers to accessing care. turn it back over to Naomi.
Thanks, Lauren. Fabulous. In addition to the programs that Lauren so eloquently spoke on, we have some really exciting programs that are based in the mental health department, but are really overarching and far-reaching across the agency. One of those being our student intern program. This is a program that's been in existence here at this agency for some time. However, only recently in the last year did we have our fabulous, wonderful Chanel Taylor, who is the director of intern training, go into this position and really hone in and take this program and really turn it to what it is today. And interesting to note is that Chanel actually used to be an intern of ours some time ago and has come back to the agency, worked her way up, and is now a director and overseeing the program. So we are fostering a foundational learning ground to equip and develop providers that will be instrumental agents of change in the community through application and learning. So some of the schools that we've partnered with are listed. We're continuing to develop and diversify more and more of the schools and training programs. We have interns that range in various disciplines. So historically, it really just started with clinical staff. We were partnering with MFT programs, so marriage and family therapy, master's level programs. And now it's really diversified into something much greater in order to address the complex needs that our clients have. And so we now have interns who are clinical, psychiatric, we have nursing students, case management services, peer support, and then we also have macro placements. So these are folks that are not necessarily placed in specific programs providing direct service, but really looking more at policy. And so we've had, for example, people doing literature reviews on diversity, equity, and inclusion best practices in social service agencies. So really thinking about how can we partner to make sure that we are also benefiting the long-term impact that this agency is having. Our goal is to also continue to expand and diversify the type of programs that we are partnering with. And so on deck, we are hoping to continue to expand into substance use counseling and occupational therapy. We also, in a fabulously and very exciting expansion this past year, has also included our ability to now provide an employment-based or dual internship opportunity. So historically, we have had staff here that we have valued greatly, have chosen to continue to move on and get a further education, and had to leave the agency in order to do so. And with the intention of diversifying our pool of folks that we are able to provide services and also retention of staff, Chanel was able to really create a program that allowed for our staff to stay here, remain employed, and continue to get that further education. That's really been an exciting aspect for us. So continuing to grow this particular program, and we have interns that are not only in the mental health department, but in our interim housing programs and also in our housing department. And we're looking to continue to expand that across the agency. Another fabulous, exciting program is our Overdose Response and Prevention program. This program got started in about 2018. This is truly our active commitment and response to the harm reduction model, as well as to prevent opiate overdoses in our community. So as you all may be familiar with, we are very much continuing to feel the impact of the opioid epidemic. And this is our way of keeping our neighbors and communities safe. And so what does that look like? Before we get into that, some sort of statistics that might be helpful to conceptualize why this is such an imperative program is that given the brevity of who is impacted. So on average, we see about 130 people in this country die every single day from an opiate overdose. More specific to our communities in the LA area and those that we're serving, drug overdoses have been the leading cause of death among people experiencing homelessness in Los Angeles County since 2017. Overdose rates have increased by 84% between 2016 and 2019. It's pretty significant. Fentanyl-related death has increased significantly in 2019 and has doubled again during the first 7 months of 2020. So pretty in line, of course, with COVID-19, less providers out on the streets, people getting their hands on what they can. And then also we've seen a really substantial insurgence of fentanyl-related overdoses. Fentanyl is an opioid. It is colorless and odorless and much cheaper. And so it is cut into other substances. And we are seeing a pretty substantial impact of people dying essentially from this. So in 2018, we applied for a medication called Narcan or naloxone. If you are unfamiliar, Narcan is an opioid antagonist. It reverses the effects of an opiate overdose and allows someone to breathe normally again. That is essentially what this medication does. It allows someone to breathe normally again. And so we applied for Narcan through the Department of Healthcare Services. We're granted that Narcan and began the program by providing overdose bags to all of our on-site programs that were client-facing. So interim housing, our access center, wellness center, project-based housing programs, as well as all of our outreach workers. In 2020, we decided to expand that program to include providing overdose bags to any and all staff, as well as partnering programs and staff that we have here. And then in addition to that, we have been providing overdose bags to community members. So we are distributing overdose bags in our programs and on our streets to those that want them. Research shows that our participants and our clients are likely to be first responders far before we are. So it's imperative that Narcan is on the streets and in the hands of each other so that they can save one another's lives. So since 2019, from the data that we've been collecting, our staff here at this agency have reversed approximately 32 overdoses, so have saved 32 lives from having Narcan on them. Just in this past year, from gathering some information from community members when they're coming back and asking for refills of naloxone or Narcan, we tend to ask some questions, and those that are willing to share, we gather some of that data. And from what we have had reported, we've had approximately 30 community members report that they themselves have saved someone's life by reversing an overdose with the Narcan that we've provided them on the streets. We look forward to continuing to expand this particular program, continuing to expand the harm reduction services that we offer here at the People Concern. We also have a harm reduction task force that is very intentionally doing just that. So ensuring that we are looking at all the harm reduction supplies that are going to best serve those that we are caring for, essentially.
So it looks like, Naomi, you and I have a couple of Q&As. I can stop the share so you can see us.
Okay, just looking at my notes. So one question was, I feel like many people are suffering from some post-PTSD or post-traumatic stress disorder over the last year. Is this something that you agree with? And what do you suggest that we do about it? Yeah, so, essentially, we have been serving folks. Data will show that the vast majority of the homeless population has experienced a traumatic incident in their life. So essentially also what we would call, which will be presented a little bit later, but a complex trauma. So multiple traumas over their lifetime. And so this is something that we take very much into consideration when we're working with folks, again, taking that trauma-informed care approach, making sure that we are talking to folks about their symptoms, different ways that we can tackle those head on, essentially partnering with our clients to talk about things like isolation, hypervigilance, their own safety, what helps them to increase that safety, partnering with our psychiatrists to ensure that medication is on board, and then also really thinking about, physical safety, right? And so ensuring that is that housing first model. How do we get people indoors? How do we help them to feel safer? Lauren, did you want to add anything to that?
No, I think it's important to consider that the we always approach it from a trauma and care for approach, but now another trauma that I think we're all kind of experiencing is COVID, so being in a pandemic. So considering that we're currently still in it and how we can serve our folks to ensure that they're safe, but also our staff are safe too. I'll take the next question. So the question is, how has COVID impacted the services you offer? Did you have limited services? That's a good question, because as I was saying, that we always want to make sure that our staff are safe and our clients are safe as well. So services were impacted a little bit in the beginning as we were trying to figure out, PPE supplies and best ways that we can serve our folks. We understand ourselves are essential workers and we provide client-facing services. We know we don't have a clientele where everyone has a laptop and we can do telehealth over Zoom or FaceTime, and we still want to provide the best level of care and services for our clients. So it was pretty challenging in the beginning, but then we got a good rhythm down. We have a director of safety, a new position that was created. So we always made sure that we were following protocol. And there were some times where there were some shutdowns of some sites, but overall we've been able to operate in a very safe way. And I think the outcomes really do speak for itself from this fiscal year that was during COVID. And we were still housing people in permanent supportive housing. We were still able to provide crisis management intervention and still interact with the clinics and hospitals to make sure that urgent safety matters were addressed, and that services weren't at a complete halt. So we did find a way. I think we have a really strong leadership team and amazing staff who really just show up with their whole hearts to do this work. So it wasn't too much of a big task to get people back out there and serving our clients, but it was challenging for a moment there, but I think the outcomes do speak for itself, that we were still able to do this work safely and protect our clients at the same time and keep them safe, and then still do the work that we do.
We have such incredibly dedicated staff, so resilient, and often very, happy to be out there doing the work during this really difficult time. So the next question is, I've heard that there is a linkage between mental illness and substance use. Why is that? Are folks using drugs as a crutch? If we look at substance use is a diagnosis in the DSM, right? So it is a diagnosable mental health disorder. In addition, there are some theories that there is, in fact, very much a medical component to it. So we are predisposed to addiction. And so, we might see that folks have a predisposition. And then in addition to that, there are stressors that happen in our lives, whether that be trauma, homelessness, whatever that might look like, that then sort of allow that to come to fruition. Oftentimes, substance use can also be a coping mechanism. So I would help to sort of reframe the idea of it being a crutch to a coping mechanism. And so if you are hearing incredibly disturbing voices and it is difficult to sleep at night, and the best thing that you have access to is a substance to help you sleep, right? That is something that you found in order to help you cope in those moments. And so we really look at folks, we all engage in some level of risky behavior, right? Getting into a car, riding a bike, whatever that looks like. And so if I get into the car, really risky behavior actually. And so we've invented seatbelts as a way to make that a safer engagement in a risky behavior. And so when we're looking at substance use, we're really able, from a harm reduction perspective, to have a very open, non-judgmental, partnering conversation with folks to say, talk to me about what you like about the substances. Tell me what you like about drinking. What is helpful? And so when we're able to acknowledge that particular piece, then we're able to tackle and partner with our clients in a very different way, right? And so, gosh, well, it helps me to sleep. And so, okay, if we want to reduce the drinking, then what are some different ways that we can do it where we can minimize those risks associated with alcohol use? And again, maybe it's getting substance use treatment on board. Maybe it's taking some different harm reduction approaches. Maybe it is having a psychiatrist come out and meet with them to talk about medications that might assist. So when we think about substance use, yes, we very much look at it as a mental health diagnosis. We very much factor that into the treatment piece of things, but we also ensure that we are partnering with our clients on what their goals are and how that is actually in fact helpful for them in coping.
Thank you, Naomi. Yeah, and we work with a population in our mental health programs where having a lot of thoughts of suicide and wanting to end their lives, and some things that keep them safe are using at times. And so sometimes that is used as a coping, and that is what's keeping them safe in those moments and from acting on those thoughts. I can answer the last question. So it's how long do you provide support services for people who are permanently housed? I am happy to share that it's indefinite. So when I first started with working with the Department of Mental Health programs, there was a time limit, but I think as funding has been added to mental health programs from Measure Age, I think they're realizing that successful long-term permanent housing does require long-term mental health care. So as of right now, both with the full service partnership programs and the housed, those services are indefinite as long as we're continuing to show that the client is needing these services, or these services are keeping them from going back to the hospital or going back to the street. And that's usually the case of most of our folks. And yeah, so happy to share that the services are long-term and as long as the clients need them, which is proved to be longer than initially they thought. So we're happy to know that they haven't put those time restrictions on it anymore.
I see that there's a few additional questions in the chat, and I think we have about 2 minutes if we want to jump into those.
Yeah.
One is, how is Narcan given? So without much more detail, maybe what I can share is that the Narcan that we have, the form in which we administer is actually a nasal spray. So that is how we administer Narcan. We provide overdose bags that look, I don't know that you'll be able to see with my background. We provide overdose bags, and we are able to provide those anytime that somebody asks for one. And so we ensure that we have training materials posted. We have our outreach workers carry the bags very visibly in order to encourage conversation. And we ensure that we are providing them anytime somebody wants one. So it's an incredibly low barrier program. We do ask for some data, but if folks refuse or don't feel comfortable, that's absolutely okay. Doesn't necessarily impact our ability to provide that service.
I can elaborate real quick on what a multidisciplinary team is. It means that a team is made up of people with different licenses, disciplines, expertise, and coming together, as we know that our clients come with some pretty complex needs at times, and we want to make sure that we don't have to send them to 5 different providers just to get the service needed. And that the multidisciplinary team model has been shown to be a very effective approach, being equipped with case management, a clinician, medical doctors, a psychiatrist, substance abuse specialist, and peer specialists as well. Peers are really pivotal in the work that we do, people with lived experience, and also people who have done this work in the community. So making sure that we're equipped with services and a team to meet the client's needs.
Yeah. Well, thank you all so much. We really appreciate you spending this evening with us and allowing us to share this exciting work that we're participating in.
Yes. And if we didn't answer all your questions, we will make sure to follow up to get those questions answered. Thank you.
Thank you.
Okay, now we're going to start the trauma-informed care workshop, and we're going to introduce ourselves. My name is Joanna Brandt, and I am a program manager in permanent supportive housing scattered site on the west side.
Hi, everybody. I'm Lindsay Weiss. I am the assistant director for our scattered site housing program on the downtown side.
Hi, everybody. My name is Mayerly Venegas, and I am the safety director at the People Concerned. So we're going to start with trauma-informed care to tell you about our philosophy. Before we start with trauma-informed care, I want to talk about, what is trauma? So trauma is very important to know, and we most have experienced this. It will be an event or series of events where an individual feels that their life is in danger, that there's harm coming to them. And the individual will experience this in a physical or emotional way. As a result of this trauma, you may have some long-lasting effects that are being described physically, emotionally, and spiritually as well. The event will overwhelm the person, their ability to cope. They may feel a sense of loss of control in their life. They may feel that they need to necessitate psychological defenses because whatever happened, it was so incomprehensible, unimaginable that they needed to create something to make sense of what just happened. What we have learned is that a lot of the trauma, it is stored in the body. And later on, maybe someone mentions about the ACE study. If not, we'll send you some information about it. But it talks about how people who have experienced trauma over a long period of time, you tend to have diabetes, high blood pressure, different diseases, and that's all caused because of the trauma that they have experienced. In this, as you see, it creates chronic health conditions. There are various types of trauma, and many of us probably have experienced the accidental indirect trauma, right? We're driving and we're all happy. Next, we're rear-ended and now we're in an accident. And we don't feel so much about it. Yeah, we're nervous at the moment, but when we get into our car again, you probably feel a little shaken. You're probably looking more in the back. It's like, am I braking enough? Is someone gonna hit me? You're paying a lot more attention. So your self-confidence at the moment of you being able to drive for 15 years, all of a sudden is shaken and is gone. So think of it, if you have experienced this over and over again, now you're talking about complex trauma, chronic trauma, it's ongoing. What we find on our clients is that they have experienced, once you do an intake, you ask questions and you hear interpersonal trauma, domestic violence, chronic and complex domestic violence, right? Because if you are growing up in that, you're seeing it your childhood. We have clients who sadly have been molested while they're teenagers. So now you have more trauma. Complex because maybe the assailant was your own family member. So you're questioning yourself. It's like, I'm supposed to be safe in this environment, and I am not. The people who are supposed to take care of me, it's not taking care of me. The other component is, in our work, we work with such a multitude of, our participants that we need to keep in mind political and systematic issues, right? Racial issues, intergenerational. We work with people who are immigrants. So we need to keep in mind what's going on in their country, that maybe that's the reason they have fled their place of living and now are here. Maybe LGBT issues, maybe there's wars, maybe they're trying to flee so that they don't have to be engaged in some gang in order to survive. All those things we need to keep in mind and be open to receive that information. We may not see it here and we go like, yeah, right. But if we really think about it and we know the history, we may see that there's a lot of things and a lot of underlying trauma that is happening for them. The other one that we need to consider too is anyone who works in the health system, in social work, law enforcement, we will experience vicarious trauma, because what we're trying to do is we're trying to connect with the individual in a very human level, right? We're opening ourselves up to receive whatever information in a non-judgmental way, and that may take a lot, that we may have experienced that trauma. And sharing that, we may create some images that we will take home with us, and we need to process afterwards to, make sure that we continue doing this work. There are various side effects of overdose trauma. So we have clients who are sometimes in one aspect very quiet, really not feeling a lot, not sharing a lot, dissociating from us. And then you have the other side of the spectrum where we will have clients who are on guard all the time, ready to, fight, and they're looking behind their shoulder going like, what's going to happen, who's going to come, and ready to answer things. And that's because, we all react differently to trauma. And we need to keep in mind that we need to have different tools in our toolbox to make sure that we're working with them. So working with them is part of our trauma-informed care. So Lindsay will talk to you more about that specific philosophy.
Thanks, Meyerly. Yes. So how do we create this cultural shift going from traditional care to trauma-informed care? So the best elevator pitch way to discuss this is going from what's wrong with you, which is the traditional model, what's going on, you're difficult, you know, all these labels, to what has happened to you that now this is what you're doing, right? We're changing the model from what's wrong with you to what happened to you. And by that, what we really mean is using behavior as communication. So symptoms, the symptoms that Meyerly just mentioned, they inform everything that we do. We don't actually need to know somebody's trauma to practice trauma-informed care. All we need to know is that they're acting a certain way, and we're going to use that as their communication. So a couple of examples of that is somebody that is on the hypervigilant side, like Meyerly mentioned, yelling a lot, always ready for a fight. We can take that and understand that they're doing that for a reason. Often the mechanisms we used to cope back when the trauma was happening or to this day don't always work still, but they're still all somebody knows. So what we always take from someone, somebody has to yell a lot or anything, what I would understand is, well, that's probably the only way they got their needs met as a child, right? So maybe they were in a lot of systems. Maybe there was just so much going on, the systemic issues, poverty, anything. They needed to yell to get their needs met. Well, now they're still doing that, even though they don't need to, but they haven't actually adapted yet because of the complex trauma that they've experienced. Another example is some paranoia or psychosis. If somebody's psychosis is really surrounding paranoia about, let's say, government systems, well, it's likely they were probably a victim of a government system at some point, right? So we're not going to tell them they're wrong. We're going to ask, how can we keep you safe right now? What can we do to improve the situation right now for you, right? You're going to be receiving this ARROW worksheet that goes from traditional to trauma-informed care in your post-event packet. But a couple of my favorite examples, just to give you an idea of how this makes sense, again, is going from you're crazy, this person's crazy, to this makes sense. If I've experienced everything you've experienced, I would also be doing this, right? It makes sense at a certain point. And then another one is people make bad choices. That wasn't really a helpful thing to say, right? I don't know where we're getting with that. Two, people who feel unsafe do unsafe things, right? If you are hypervigilant forever and you've only experienced unsafe life, that's what you're going to continue doing, right? What does safety even mean to you? So it's about reframing those things. And then going from power over somebody as service providers, we should not have power over our clients. We want to have power with our clients. We are providing resources and examples of things to do, and they are taking the lead, right? We're using empowerment and self-determination. So when somebody's housed, they should be thanking themselves, right? They shouldn't be thanking us. They should be really proud of themselves that they got there, and we are just there to help. We are not there to do it for them. So encouraging them to make their own choices and doing all of that. Generally, when you tell somebody what to do, they don't want to do it very much, right? But when you are just helping them and giving them the options, they're going to choose most of the time the right thing, right? But sometimes they won't, and we're still there with them, and that's fine. So it's really going from a powerful, dominant model to just, all right, let's do this. We're all along for the ride, whatever that means. So Joanna and Meyerly are going to talk more about the tenets of trauma-informed care and how this works.
So yes, so as you heard, that our trauma-informed care, it has very strong ideas of connecting with the individual one-to-one, human level, right? No power over. And that means creating a safe environment. That's physical safe environment, that means emotional safe environment. In the physical, we have been very mindful to make sure that we're not welcoming people in a place and the first thing they see is a bunch of rules of what not to do. That's not really welcoming. The same thing as making sure that we have signs that if we have someone who's from the LGBT community, that they feel safe, that they feel like this is someone who knows about my culture, my beliefs, who I am, and I will be welcome here. That's very important for us to have. And with that, it creates trustworthiness, which Donna will tell.
Trustworthiness. When we partner with clients, we want to build trust between us and the client. And that makes them feel safer to engage in services. So we want to be transparent. We want them to understand the process and not just be something that we show up and say, do this, do that. We want them to understand what they're getting involved with so that they can trust us to walk them through it. Having boundaries with our clients so that we are actually empowering them to have boundaries in their own lives. Offer explanations when things don't go exactly the way we had planned or things change. Following through, keeping appointments, calling when we say we'll call, being consistent, holding appointment times, again, following through with those things with our clients, and always having a cultural consideration. Thinking about the experiences of certain cultures and how trust may be a very difficult thing for them, especially maybe there's a cultural difference between the worker and the client, that we have choice.
And choice is very important, like Jenna was mentioning. The only way to create that trustworthiness is if you provide choices and options for our clients. Many times when I used to do participant client-face services, I heard it a lot from our clients saying, what are you going to do different from the other programs? And our clients have been to different agencies, and maybe the service have been different. It has been more in the typical way, power over. And when they come, they're going like, oh yeah, you're going to be just like everybody else. You fill out your paperwork, you check your boxes, you tell me what to do, and that's it. So we really need to create that safety, that trustworthiness by providing the choices. Like Lindsay said, we're here for the ride. So, okay, where you want to go? Here are some options. Here are some possible consequences to those actions and choices that you're going to make. Which one do you think you'll be comfortable with? And we'll go from there. By creating that, we're listening. We really have to listen. We can't just be, I'm thinking what I think it will be best for you, and let's try to convince you there, because then I'm not being really clear and transparent right here. I'm having my own agenda, and that's not going to work. But our clients will read you, will look up and down and like, oh, I see what you're doing. You're trying to convince me to do what you think is right for me, and that's not going to work. So we really need to look at the individual in a holistic way and making sure that we're following all of this to, really create a very honest and transparent relationship to empower them.
Exactly. So empowering the client, believing in them, knowing that they do have strengths, they do have resources and resilience, and they can make their own choices. Teaching skills, but again, collaborating with the client based on seeing what their strengths are, acknowledging their strengths, helping the client to see their own strengths. And that in turn will restore hope. If they feel like they've got some power, again, power with, not power over, and always keeping that cultural consideration piece a part of the conversation as we collaborate.
Exactly. So as you see, all of these pillars of trauma-informed, are building up to really create a connection with the individuals that we work with. That collaboration is super important. It's an equal partnership. I used to be a director of a site, right? And the clients usually will tell me, well, you're the director. And I knew that there was a power imbalance, right? I'm the director. So many times people will just go like, okay, well, you're the director, I should do things. Because of whatever may have happened in their experiences, right? A lot of people, people over 30, sometimes you follow what it is. But I always told my clients, I'm just an individual that happens to know more information because of where I live, what I've done, all of that. And I'm here to share with you my information, and whatever works for you, great, let's jump on that. But if it doesn't, no worries. We'll just revise our plan and go from there. That shared power creates all of what we're talking about, that empowerment, that trust right there that we really, really need to create a long-lasting relationship and rapport with our clients. They need to be part of this, because I can tell you what to do, but if they don't believe it, if they don't act the same way that I will act, then the outcome will be completely different. And the next thing will happen is that they can turn around and say, you told me to do A, B, and C, and it didn't work. Look what happened. Our rapport just broke right there. You need to build that all over again. That's going to take a lot more work. we're trying to repair that relationship that may have happened, have been broken with many other sites, many other locations, many other programs. And we're trying to make sure that we're having that rapport again. We have accountability. Just because we work with our clients and we're trying to be tactful and mindful of their feelings and fears and everything that happens, doesn't mean that we're not going to be making them accountable, right? We go, just like us, we go like, hey, my fault, I didn't meet with you, that's on me, and I apologize for that. I'm gonna make sure that I make it up to you. Let's do A, B, and C. That's accountability. Like I have accountability. We also ask for our clients, okay, well, if you didn't want to do that, that's fine. Just let me know. We don't waste your time. We don't waste our time. Let's jump in something else. It's having those hard conversations with our clients that really create the rapport that we need. And that's built in language.
And in that, definitely language is so important. And we always want to remain positive and respectful with our clients, and respectful in a way that validates their life experience, their knowledge, their experience. We don't want to be punitive. You know, there are going to be missteps in the journey with our clients. There's going to be obstacles and barriers, but we don't want to make our clients feel like they've done something wrong or done something bad. We want to look at the situation, process it with them, help them work to a solution together with you. Again, and non-demanding. So if you're applying for a housing voucher and you've got deadlines and you need certain documents, presenting in the client in a way that brings them into the process instead of saying, I need this by this date, you need to do this and you need to do that. You know, helping them to understand a timeline so that they're working together with you and collaborating on it. Always being mindful of tone and body language. Am I talking in a way that's respectful? Am I talking in a way that's curious? Or am I talking in a way that's condescending or assuming they should know something or that I know better than they do? And that very much ties into all of our cultural considerations between us and our clients, acknowledging differences, asking and being curious about how they would like to be spoken to, how they would like to work through a process according to their background, and maybe they need an interpreter because their first language is not English. Maybe they prefer to meet in a certain space because of cultural considerations in their home. Always kind of acknowledging that and being curious and asking questions about what will make the client feel more empowered and more comfortable. So those are all the tenets that we base our trauma-informed care in. And now I'm going to turn it over to a video. This is a video about empathy, and it's very cute and very informative from Brene Brown. So enjoy.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Oh, so nice. All right, so just a couple of discussion questions from that video, because the reason we show it is because trauma-informed care requires a lot more. That's often the reason it's not done and it's harder, because it requires us to have empathy all the time. And so it's really difficult. So we all can do this, right? I always love this video because it just reminds me always to stop. Don't at least yourself, first of all. We all at least ourselves a lot. And she uses silver lining as a verb. Now I use at least as a verb. But have you all ever gotten a response silver lining an issue rather than just listening and providing empathy? And you can enter in the chat if you want to share, no pressure. To get it going, I can share. I was in a car accident last year, and the response often was, well, at least it wasn't worse. And I'm like, yeah, I know that, I understand that, but it still was scary and it still made me feel these things, right? So it doesn't really matter that it could have been worse. Let's just sit with me right now in my feelings, right? So that's an example. And then another just food for thought question is just, what do you think would happen if more people tried to feel with the folks that we work with rather than have the sympathy, right, in that distance? If somebody really put themselves in that situation, what do you think people's minds would change maybe? I don't know. Just if anybody wants to volunteer anything. Yes, in the chat. That's all right. Folks' minds would change. It will take them being willing to be vulnerable. Yeah, I mean, I think that's the crux of it, right? It takes a lot out of us to provide that empathy. Well, if we are providing a lot of that empathy and being really vulnerable with ourselves, we also need to take a lot of care of ourselves, right? And so Joanna is going to talk to us about having a wellness plan for ourselves.
We all have stress every day. Obviously, a lot of us have trauma in our past. And so taking care of ourselves is definitely an important, thing we should be practicing on a regular basis. And that we might think we don't have time, or it's not important, we're the last person to take care of ourselves. But these are just some things that you can do to think about, to make a plan for yourself to take care of yourself. It could be just to, get outside, go for a walk, ask for support. Turn off the news would be really helpful, I think, these days. Taking a break, even if it's 5 minutes. Journaling, meditate, small or as large as you'd like to make it, but we would really encourage you, as we like to encourage our clients, to practice some self-care. And we tell each other in our jobs too, to keep us going in this work. So if you feel like you'd like to share any ideas for self-care, things that you like to do for self-care, please do so in the chat. Yes, Having a dog is very good self-care. Always works. Hiking, anything with nature, just changing your environment, getting outside. Taking a pause breath, taking a sip of water, moving about to change my position, mental, physically, and emotionally. Love that. Some people say putting an ice cube in your mouth is a good brain pathway changer.
Somebody shared earlier, sharing with help us find common ground and know that our burden can be shared and we are not the only one that has handled it. So that's powerful too. Create a sense of community.
Yeah, I think that's so important too, because even though it takes something out of us, it does create more connection, right? It's worth it in the end.
Okay, so now I'm going to send it back to Kate Berman. Thank you so much for being with us this evening.
Thank you everyone for joining in tonight and tuning in to this program. We are grateful that you are here with us. And thank you to our amazing team for sharing their work with you all tonight. And we are grateful to have had everyone. Please stay tuned. We will be emailing you a recap of this event to your email addresses. And with that, have a great night.